We're going to be talking about partnering with hospital emergency departments, practical experiences from Ohio Deflection Teams, and we're really so happy that all of you are here to join us. The Substance Use Deflection Initiative, so we provide training and technical assistance to support overdose response, substance use response, harm reduction, other deflection efforts. And we'll be hosting similar statewide sessions throughout the year. So if you'd like to stay informed, you can join our deflection mailing list, and Mari's going to drop a link to that if you aren't already on there. So today we're excited to hear from 3 different teams around the state who will share how their deflection efforts sort of intersect with local emergency departments. From Franklin County, we have the Southeast RREACT team. From Columbiana County, we have their mobile crisis response team. And from Montgomery County, we have their recovery outreach team. So before we begin, there's just a couple pieces of businesses that I want you guys to be aware of. So this session is being recorded, and it's going to be posted on our website and shared in our newsletter once it's been completed. We will reserve 10 to 15 minutes at the end for Q&A. So as people are talking, feel free to drop your questions in the chat, or during the Q&A session, feel free to raise your hand or come off mute. And then finally, a short feedback survey will pop up in the last couple of minutes. So please take a moment to let us know how this was for you and what we can do to make it more useful to you in the future. So we're going to start with quick introductions from the Deflection Initiative team, and then we're going to turn it over to our speakers who will introduce themselves at the start of each of their segments. So again, thank you for being here. We're glad to have you. My name is Ashley Morgan. I'm the director of the Substance Use Deflection Initiative, and I will hand it over to Amari.
Hi, everyone. My name is Amari McGowan, and I'm the program coordinator for the Substance Use Deflection Initiative here at NeoMed.
Thank you, Amari. And first up, we're going to hear from Franklin County's team, Southeast RREACT. So James, I'm going to hand it over to you and ask you to introduce yourself and your team, and then go ahead and share your program.
My name is James Alexander, and I have joining me is Peter Levitas, who is our clinical person on the RREACT team. I have been with RREACT since 2019. Peter has been with RREACT since, I believe, 2020. You could jump in and you can just correct me if needed, Peter, or at any time that's in this presentation, because I'm sure that you know more about this than I do. So, and RREACT started in 2017. Initially, RREACT was partnering with Columbus Division of Fire around 2018. RREACT started going into 9 local emergency rooms, split into 3 zones. We also have a clinic phone, again, that Peter is the holder of, who responds to all community calls. We also respond to freestanding and urgent care centers throughout Franklin County. Our hours of operation is Monday through Friday to 4:30 until 10:30 p.m. Saturday from 9 to 9:30. Sunday 9 until 5. Work that we do is challenging, but we also have a lot of successes. So I'll share some of the challenges, but I also see this specific challenge as a success. Some of the patients that we encounter are repeat customers, as we call them. They will go to the local emergency department and request Southeast services. At that point, one of our outreach coordinators will go to that emergency department. We not only go when we are called, we make 2 in-person trips per shift. We also work with Columbus Division of Fire, who sends us alerts whenever a patient is being transported to one of the 9 emergency departments. At that time, we will respond. The outreach coordinator will respond, assess the patient, and then link the patient to treatment. But there are several things that I believe unique about the work that we do. And one of them is every month, the second and fourth Wednesday, RREACT invites a community treatment provider to present their program. The purpose of this is in our referral list, and we send people to Dayton, to Cleveland, and even a couple of times from out of state. What else is unique about Southeast RREACT, I believe, is that we are in constant communication with our coordinators and our peer supporters through a cell phone. We have set up 2 group text threads that is constantly being utilized to share where staff is located, as well as the patients that Southeast RREACT is engaging. One success I wanted to share is I was in a meeting with one of the hospitals recently, which we hold a quarterly meeting. But in this meeting, one of the social workers said, we only call RREACT when we have a difficult case. And that's the majority of the cases that we see. Interviewing, most of the staff is certified in substance use disorders. And finally, this work allows us to really expand and to help a lot of people. One thing that we do that I think is unique as well is our clinic phone that Peter holds. We get calls from family members, from hospitals that's outside of our zones. We get calls from businesses and so forth that is requesting Southeast RREACT intervention with patients with a substance use disorder. And thank you for your time. I appreciate it.
Thank you so much, James. And again, if anybody has questions about their program and how they work with hospitals, please feel free to put it in the chat. James is gonna hop off early around 10:30, but Peter's gonna stick around, so we'll have someone to answer questions about their program. So thank you, James. We are now going to shift over to Columbiana County's Mobile Crisis Response Team. I'll ask you guys to introduce yourselves and then you can go ahead and get started.
Thanks for having us today. My name is Lori Colian. I'm the Director of Treatment and Supportive Services here at the Columbiana County Mental Health and Recovery Services Board. I have in the room with me, go ahead.
Hello, my name is Glen McMillin. I am one of our supervisors for the Columbiana County Mobile Crisis Response Team.
And I'm Jaime McMillin. I'm the other supervisor of the Columbiana County Mobile Crisis Response Team.
And good morning, I'm Marcy Patton. I'm the Executive Director of the Mental Health and Recovery Services Board. And on camera, if you wanna.
Yeah, and Melissa, would you introduce yourself, please?
I'm Melissa Dwyer. I'm from Salem Regional Medical Center. I'm the Director of Risk Compliance and Case Management here at the hospital.
Thank you. So as you can see, we formed a mobile crisis response team in 2021. Next slide, please. It's kind of the two reasons that that we started looking at enhancement of services was because of the high overdose rates that we have in Columbiana County and the familiar face presentation to the hospitals and law enforcement. Next slide, please. So before we talk about how we got to before we talk about the specifics of the hospital partnership, one of the things that we wanted to just briefly touch is that how we got to even looking at the hospital partnership. We had a hospital social worker reach out to the board previous to me, but to Marcy, due to the high volume of familiar faces that continue to present in the emergency department and the seemingly lack of continuity of care. So they had a lot of meetings, and I know Melissa and Marcy were part of that. They explored resources and programs that could provide assistance. Melissa found a care team model that was developed in another state. And so then Columbiana County sat down with numerous agencies to develop the community care team that provides kind of a wraparound type of service to individuals identified and agreeable to this voluntary participation. Continued conversations occurred with agencies on the enhancement of crisis response. Next slide, please. Thank you. So that was about the same time Ohio lost there in 2020 before the world shut down, had their first crisis academy that we attended to look at what other places, what else was going on throughout the state of Ohio and throughout the United States. We formed our crisis development team committee following that crisis service that has just different entities that included the hospital, mental health agency, our Department of Jobs and Family Services. We had Salem PD and an on-demand, another mental health agency. We had kind of a vision for what mobile crisis response team looked like. And we talked about including the use of certified peer supporters at that time. So we kind of jumped in head first, developed some policies and procedures for the mobile crisis unit. We had numerous discussion with law enforcement to get buy-in on their end. We had a chief that two taglines that we would go by all the time that stated he couldn't arrest our way out of the problem. And another tagline was just if we had someone to call when we're dealing with the familiar faces. So that was on the law enforcement side. So we had pretty much buy-in pretty quickly. But again, we had Salem Regional, Melissa was part of all of these meetings. Next slide, please. So now we're just going to delve right into the development of what things look like towards the development of the MOU and some of the things previous to the MOU. So I'm going to let Marcy speak to that. And Melissa, if you.
And you can jump into Melissa. So as Lori said, we had been having conversations for some time with the hospital around some of the needs. And so as we decided we would like to develop this response team for the county, we decided, of course, to do this pilot project specifically in the Salem area because Salem Hospital was on board with us. So then, of course, you have to develop, as she said, some of these policies and procedures and MOUs and the hospital was very supportive. So we ended up speaking with the hospital CEO, Dr. Hackstead, and other administrators at the hospital. And kind of went and met with them, and they showed us around the hospital and said, hey, we have a little bit of space here, maybe we could let you use this particular space. So, we developed an MOU, and basically that first MOU was all of one page, very simple. It was one single letter, that Dr. Haxton put together. It was really focusing on the use of the space, you know, some logistics like internet access and protected health information. It was kind of defining the role a little bit, and this was one of these situations, we were building the airplane as we were flying it, so there was still a lot of things we needed to determine. We were making sure that the agencies involved were carrying their own liability insurance, that, you know, the hospital, you know, didn't have any responsibility, that the team was not representing themselves as part of the hospital at that point, and that everyone was wearing appropriate identification, just some really basic kinds of things at that point. As I said, it was all one page. The legal things about how, you know, we could terminate, this partnership if needed. And that was, developed on May 5th of 2021, so almost 4 years ago. We really haven't changed that MOU, although some of the things you'll hear have changed since then as we've learned. And we typically signed that with the typical providers at that time, which was our counseling center, our local community mental health center, which was providing some 24-hour access, but more specifically with on-demand counseling was who had hired our peer supporters. I will say the reason we decided to go with peer supporters at that time was probably several reasons. One being that it was, although not easy to find peer supporters, it was easier than finding clinical people at that time. And we really valued the importance of the lived experience and felt that that would be really beneficial as we were trying to engage with individuals. And as you'll hear from them, I think that was a wonderful choice. We're at the point now we want to add maybe a clinical person to the team, but having, you know, that buy-in from people right up front with the lived experience piece was just so valuable. So really it was very simple. We also developed, you know, MOU with the agencies, between the agencies involved, but they were not a real big deal. Later on, we, you know, had some other legal things that came up, and so we decided to do a couple other things, which we'll talk about in a couple of minutes, but it was really a matter of having a couple of willing partners who were ready to come to the table and said, we need to do something. And we know that people come to the hospital and that they're at a point then that they really need the help, and what can we do to help them? Talk about barriers and challenges. Oh, yes.
Can I kind of add in here?
Sure, go ahead.
From the hospital perspective, if we go back to the community care team formation, I used to run our outpatient mental health treatment program. We have a PHP IOP program here at Salem. And one of our problems with being a small community hospital, we don't have access to an inpatient psych unit. So police would police would bring people into the ER, would pink slip them. They would sit in our ER for 3 to 4 days, and we really couldn't get them anywhere inpatient. And so we would determine that they were no longer a threat, and then we would discharge them back. And it was very frustrating for everyone in the community, you know, because we know we're not giving them what they needed as far as treatment goes. And it was just this cycle of people just kept coming back to the ER. So we started it with the community care team to kind of see how can we coordinate services and really get people set up with services when they were discharged. And then Salem police and fire said, you know, we're going to start transporting people to a hospital that has inpatient psych access to get them the treatment. So that has helped because we don't have people sitting in our emergency room that we can't treat, but there's still going to be the time when we get people here that need treatment. And so that's kind of where the crisis team stepped in. Right, Marcy? Does that sound?
Yes, that sounds accurate.
So that's kind of how it all, you know, came to fruition, I guess you would say.
Lori mentioned too, I forgot this was on my slide, sorry, the barriers and challenges. Some of the things we faced early on is, this was early in, the spring of 2021, and we were just coming out of COVID. The hospital staff were pretty overwhelmed still and pretty burnt out. And they were, had lower numbers of staff. They were struggling with staffing issues like everyone was at that point. We needed to build some relationships with the agencies, to integrate with the hospital and make sure people knew each other. So that took some time. I think there was a lot of difficulty understanding roles and responsibilities of certified peer supporters. It wasn't a commonly known service, and so nobody really knew who they were or, what the situation was and how they would be working. And there had also been a number of staffing changes with the agency that we were utilizing to hire the peer supporter, especially in the supervisory role. So we, kept having some differences in how things were done. And those first couple of years, we faced a lot of different aspects with peers working in the hospitals. Issues with liability and paperwork, documentation, voluntary access to patients, and all of those things led to privileging of the peers, which we will talk about here in a minute. So at this point now, we've gone through a lot more kind of legal compliance, and the hospital, I think, has worked closely with us to ensure that our peers have access, but also have some protection because they do go through the privileging process. And I'll turn it back over to Laura to share about that.
Next slide, please, Ashley. So, the peer supporters are making application for privileges in 2023. So that they were able to go into the emergency department and onto the units. The Salem Regional Hospital Board had to approve these privileges. And this allowed certified peer supporters to meet with the numerous individuals that were identified. And of course, it's always on a voluntary basis. They ask them, if they're interested in who they are and if they would like to meet with them. This allowed hospital staff to share face sheets with peers, and feedback forms from peers regarding outcomes to be placed in patient's file if it was applicable. Okay, next slide, please. So I'm going to kind of turn this now over to Jaime, Glen, and Melissa to talk about the emergency room response and the success and challenges and what does it look like now.
Thank you, everyone. So Jaime and myself, she's my wife, so I think I can speak a little bit for her in this and saying that we sort of had kind of an idea going into this, what we would have liked it to look like, both in our individual lives personally, when we were going through our struggles. We both encountered peer support in a hospital setting. Mine was after an overdose. Jaime was when she was going through a liver transplant for alcohol cirrhosis of the liver. So we sort of had an idea, the dream and what it can accomplish. Peer support's a very disarming and engaging tool when done correctly, and we wanted to make sure that that's what we did. So with getting the advanced practice provider staff privileges, we were able to then go into the emergency rooms for things like, say, following an overdose or alcohol related illness or injury or any type of mental health crises. We're also able to go to the ICU and speak to some familiar faces there, as well as the medical floors, which I'm you guys would like to share that a little bit. So basically what we would do then is we would go in and we would model recovery and stability. Obviously we're certified peer supporters, we're not clinicians, so we can't diagnose, but we can assess what we're seeing. We share our lived experience and pieces of that where it fits, and then just provide the resources and help these individuals make contact with the resources. We work very well in tandem with case management staff in our hospital. And I'd also like to add that we're actually in both hospitals now in our county. We have two hospitals Salem Regional Medical Center and East Liverpool Hospital. We're having a lot of success in both, but we are able to help both the hospital staff and in the community by eliminating the interactions that these familiar faces. I've been doing this since February of 2022, and I think I can speak to all of us that we're very excited and blessed to see the outcome of this program. But we've seen a lot of our familiar faces actually gain success, and now they're actually working in the community. They're tax-paying citizens. They're no longer overdosing on the streets and causing chaos.
We have about 2 minutes. So Melissa, do you want to add anything as far as the hospital perspective, as far as what your staff's seeing real quick before we wrap up?
Yeah, from a hospital perspective, nurses were a little bit biased, especially when it came to our substance abuse, and they just come back and they don't get clean, and why are we doing all this when they're just going to end up back here? And having the peer supporters come in and seeing the success has really changed our nursing staff's perspective and our physicians' perspective. Usually from case management, we don't even get a chance. Like usually nursing or the physicians have already asked us to consult peer support before we even go in and see them. So everyone has really bought into the service, and we appreciate Glen and Jaime and Keith and Randy and everyone who comes and helps us. Even if we had I'm gonna tell this story real quick because it speaks to the success. A girl that came into X-ray, she just came in to get an X-ray, and she told the staff that she was struggling. They called me down. I went down to talk to her. I found out that she had been clean, I don't know, a few months, and she had just moved into our county. So I connected her with Keith, one of the peer supporters. He got her set up with some outreach stuff, and she's been maintained her sobriety for 6 months now. So I'm sorry, I get emotional about it because I think it's just so great.
Thanks, Melissa. So actually, please feel free to share the slides. Our contact information is on the last slide so that everybody would have it. So if anybody has any questions or wants to do a reach out, all our emails are on that. And we thank you again for letting us speak to what we do here in Columbiana County. We're very proud of this program. Thank you.
Thank you.
Thank you guys for being here and for sharing and for offering to share your slides. We'll send those out after this session. So now we're going to transition over to Montgomery County. So if you guys want to share your slides, introduce yourselves, and go ahead and get started.
Hello, everyone. My name is Randy Carmack. I am the Community Outreach Supervisor for Public Health Dayton Montgomery County Recovery Outreach Team. And then I have my colleague here, and I'll let her introduce herself.
Everyone, thank you for this opportunity to speak to you. My name is Dawn Schwartz. I run the Community Overdose Action Team, which is a community coalition that works in Montgomery County to reduce overdose deaths and substance misuse. So today, Randy and I come to you really excited to not only speak to you about our hospital partnerships in Montgomery County, but also some of the data analysis outcome that we have recently been able to get in the last 6 months, and we are starting to share not only statewide but nationally. So the first thing that I'd like to do, I want to share our screen. Make sure everybody can see this. There we go. Okay. So we're going to be talking about our peer support and clinical services for our hospital community in Montgomery County. Obviously, just to do a real quick update, everybody knows or should know what peer supporters are: lived experience of recovery with substance use, gambling disorders, other challenges, who then work in the community to provide guidance, understanding, and encouragement to others who are facing similar struggles. So that lived experience and that personal journey to be able to offer support really build hope and help connect people to resources, is a really, really important part of them, of us helping them navigate their recovery process. I'm going to go ahead and hand it back over to Randy. I'll be popping in every once in a while during his presentation with some more points. But Randy, I'll go ahead and hand it back to you.
Thank you very much, Dawn. And again, I just really want to talk about the peer support and the importance of peer support in our community. I hold my master's in social work, and God willing, I here in a couple months, I'll be done with my supervision and I'll be able to test for my licensed independent social work license. I'm pretty excited about that. That's coming up. And I also have my licensed independent chemical dependency counselor license as well. But I'm really proud to be a certified peer recovery supporter. I still maintain that certification because there's really nothing that can match a person that is able to share their lived experience for identification purposes with individuals that are struggling with substance use disorders in our community. I think that the peer support profession is really important for people in our community so they are able to get the services that they need and then have people that they can relate to and say, hey, this person gets it. This person knows where I've been at, or at least a similar story to where I've been at. So I think that it's really important to acknowledge peer support as a profession because that's what it is. It really is a profession, just like social work is, just like chemical dependency counselor is, and then other professions as well. So I want to start up talking about the importance of partnerships whenever we're talking about working in the hospitals. Without partnerships, we really would not be where we are at. We started our program in June of 2017, and we started working in the courts and with law enforcement. And it quickly transformed as we began to build relationships to working within the hospital setting. I really want to talk about, the wonderful partnerships that we have with treatment centers that are in Dayton and Montgomery County and really across the state of Ohio. Without building those relationships with outreach workers for treatment centers, we really would not be able to serve the individuals that we contact in the hospitals that are struggling with substance use disorders. So that's a really important partnership to build, is get with your local treatment providers, put your feet inside of their treatment centers, see what type of care they're providing, and then find a person that works for that center that will help navigate getting people into their centers in a timely manner. And then additionally, we have partnerships, and Dawn is my grant writer. Without her, none of the work that our team does in the hospitals would be possible. And we have in our grants a partnership with Gadaha and Ascend Innovations. Gadaha is the Greater Dayton Area Hospital Association, and they're the parent company of Ascend Innovations. And Dawn, if you would, will you talk about Ascend a little bit and why you wrote them in our grant?
Yeah, absolutely. Thank you, Randy. So I'm going to be brutally honest. Randy has been here from the beginning of this. I am the latecomer to this. I transitioned into this position about 2.5 years ago and was able and lucky enough to have predecessors who worked with Randy's predecessor, Gary Ganella, and Randy's team on how we wanted to fund this and how we wanted to structure this. So part of that was, again, finding not only partnerships with the hospitals. We've got two major hospital systems in Montgomery County, Kettering Health Network and Premier Health. Kettering Health Network is our main partner. And within Kettering Health Network, Randy and his team works with a team called the BAT team, the Behavioral Health Assessment Team. That's the social worker team that is, called to different rooms by doctors and nurses, other medical personnel, to start the process when somebody has substance use and getting them linked with Randy's team. The importance of our partnership with Ascend and Cordata Health and why they are written into our grant. We have a BJA grant. I inherited one for $1.2 million that already had them written in to do our data analysis, our data collection, and then also build a information system that would send daily emails to Randy's team 7 days a week, showing people that have landed in the hospital or the EDs, the emergency departments, that have some type of substance use, either diagnosis or they're in for an overdose or a medical issue related to their substance use. So Ascend is our almost our kind of like data partner. They've built the APIs, they've built these networks to be able to have this communication. They push everything through Gadaha into Cordata Health, and Cordata Health is the one that sends the daily emails letting us know who we need to follow up with. That $1.2 million BJA COSIP grant did end in 2023, and I was lucky enough to be granted another BJA COSIP grant in the amount of $1.6 million in 2024 to fund this work for several more years. Without these data connections and these data networks, we would have a much tougher time doing what we're doing. No social worker has to call us. Nurses don't have to call us. Doctors don't have to call us. Our people don't have to go into our hospitals and that network blind. We know exactly who we are going to do intervention with, and we know where they are for the most part, and reach out to them in a quick response team or a post-overdose type of program. So in just a little bit, I'm going to talk a little bit about the outcomes that we have been able to see from a data analysis that Ascend Innovations did on our data that Randy and his team inputted between 2018 to 2022. But I'll get into that in a few minutes. So I'll go ahead and hand it back over to Randy.
Okay. Yeah, so it's really important to learn from other people's mistakes. Dawn, if you'd go to the next slide, one of the things, so I started off here in August of 2017. I was the first peer supporter that was hired for this program. And I remember I was young in my career, I was eager, and I went into the hospitals with my cape on, ready to save the day. And, we were getting all these real-time notifications through our Cordata health record system. And I was going in and I was immediately contacting emergency department physicians. Well, the emergency department physicians were like, well, who's this guy coming up in here talking about he wants to see my patient? They weren't too thrilled about the idea of a peer supporter coming in and taking over their case, they wanted to work internally with their social work teams. And that was a real quick lesson learned, right? So that's whenever we started to form the relationship with the behavioral health assessment team. And they are the social workers that the physicians in the emergency departments and on the medical floors refer to that team. And then we work collaboratively with that team. And they're the ones that are the experts in how the hospital system works. And without that social work team, we wouldn't be able to do the work that we do. So what we then do is the recovery outreach team will then connect with a patient who is in the hospital that has given consent for us to come in and work with them, because the social work team has to go talk to the patient before we're allowed to go in and talk with them, because they have to give permission whether or not they want any help. So the recovery team will go in, talk with the individual, share their lived experience with that person, and say, okay, what insurance do you have? Do you have any history of mental health? What medical comorbidities do you have? What are your barriers that you have that is keeping you from going into treatment? And then our team's job is to remove all of those barriers. Now, the social work team in the hospital, what they will do is they will, Dawn, if you want to go to the next slide, please.
Can I interject really quick?
Yeah, go ahead.
So this is where, when Randy spoke earlier, this is where these really close partnerships with your treatment providers, not only in your county, but maybe statewide, or if you have the ability to make national partners, is really important. Because, it is not, I know that a lot of hospitals, and again, well-meaning people do well-meaning things that may not always be effective. A lot of hospitals will, give a piece of paper to somebody going, okay, here, go ahead and reach out to this place and they can help you. Well, that person never reaches out. So having the linkage with our Kettering health partners and the ability for Randy and his team to go in, if somebody is ready for treatment, whether it's when they get released from the hospital, or if they've already been released from the hospital, and this is a community contact as a quick response team over to post-overdose follow-up, Randy and his team have the ability to get people into treatment pretty much immediately. And that's because we don't have to go through like those intake lines or call lines. We have connections within those treatment communities and those treatment entities that instead of calling the intake line, I'm calling Jill. And Jill is the intake person that works with us and can get somebody in immediately. The community that Randy has built for this team is amazing. I always tell this story that I randomly got an email. Somebody saw the COAT website. They were out in California. They said, hey, my nephew is struggling. We really need to get him into treatment. I'm having trouble finding help with this. I turned it over to Randy, and Randy had a treatment connection for this young man within an hour. So those partnerships are just as important as the partnerships that we have with the hospital. So go ahead, Randy.
Yeah. So, again, the shared experience is important. And then I was talking about removing all the barriers, right? We have a lot of individuals who are living homeless, and they have a dog or they have a pet of some sorts, right? And they're like, I can't go to treatment. I have my dog, and it may be the only thing that they have. It may be the only friend that they have left in the world to them, right? And that's a real thing for them. It's really important. So one of the barriers that we remove is finding foster care for animals. right? If a person has transportation barriers and they're not able to get to treatment, say that they have a mental health diagnosis with a very difficult insurance to place, and the closest treatment center is 2 hours away, right? Well, if we know about treatment providers all across the state of Ohio that takes this insurance with this mental health diagnosis, and they don't provide transportation, well, then we'll put them in our vehicles, and then we will provide transportation to that individual to make sure that they get into treatment, right? So we want to make sure that we are doing the best that we possibly can to address all of these barriers. And some of the goals that we're trying to meet is we're trying to reduce opioid overdose deaths, and one of the ways that we do that is we provide Narcan or offer Narcan to every single person that we come in contact with. They may not be using opioids. They may be using methamphetamines, but in our supply here in Montgomery County, there is fentanyl in almost every single substance that is out there on the streets. So we want to make sure that we are providing Narcan to every single person that we come in contact with. We also want people to know that they do have their own choice for their own pathway to recovery. So we educate people on the different pathways that may or may not work for them. We just want them to have the general knowledge. And then additionally, something that we do is we increase public knowledge to reduce the stigma. We provide a substance use disorder 101 training that really talks about the biology of addiction and how it impacts the brain. We present to Kettering College, Wright State University, local churches, and we get this education out into the community through any channel that we possibly can. And then we want to increase engagement in treatment and other needed services to reduce overusage and impact other community systems such as criminal justice and healthcare. Dawn, will you go down 2 more slides?
I just want to jump in and let you guys know you have a minute or 2 left. Want to
Okay.
make sure we have time for questions. Thank you.
Okay, and then I'll go through. Dawn, you want to go through the data real quick, or do you want me to?
Yeah, I'll go through it really quick. So they did a deep dive between 2018. Actually, this says 2019, but it's 2018 and 2022 on 3,000 referrals from Cordata and Ascend, the hospitals, to our QRT team. Of the referred, we didn't have contact with half of them, 1,500, and then we did have contact with 1,500. We had, with approximately 1,000 individuals, 1 contact, approximately 300 individuals, 2 contacts, and then about 250 people, we had 3 or more contacts. So if you look at the total interactions with local systems of care, and you look at the number of QRT contacts, as we go from 0 to 3, you can see where it jumps from a 6.4% change to a 53.6% change before and after QRT. So we are showing through data that we are having an impact on local systems of care within our hospitals. Also, when you look at if people had contacts 1, 2, or 3 or more, there is a hospital charge difference where 1 contact can save $9,000, up to 3 or more can save $22,000. And then we keep going when you look at total Medicaid and reduced hospital charges. And obviously this affects a Medicaid greatly because most of our people are under Medicaid insurance. So at 3 or more contacts within this time period, we were able to reduce hospital charges, a lot of Medicaid charges, by $42,000. Over that time period, we saved about $26.6 million in Medicaid funding by the work that our QRT team is doing. So again, this is our team of peer supporters. I fund about half the team right now. I'm looking to expand that, fund the entire team, look at sustainability. We have 7 peers. We have 3 LSWs. So we do have the benefit of if somebody does need an assessment, they can make those, do those assessments and make those recommendations. And lastly, I just want to touch on again, how is outreach funded? This is where I come into play. I do the grants that fund half the team. Randy and I have currently been partnering with Ascend and Cordata to do some education and lobbying in a way at the state level. We were able to meet with the governor's office, OMAS, Ohio Department of Public Safety, Recovery Ohio in February, and give our outcomes with the cost savings and what we've been able to do in Montgomery County. And I just got an invitation to go this summer to DC, to the Hill, to do something similar. So we are using this platform to not only, we don't want to be grant dependent forever, right? We need to find other sustainable ways to fund this. So that's what I am currently working on now. Data and strong partnerships are key. We've already talked about this and what we've been able to build with Ascend and Cordata. And then our results in Montgomery County, since 2017, we've had a 49% decline in overdose deaths since between 2017 and 2023. And just so you know, in 2023, we had 293 overdose deaths. And then in 2024, we had 175. So we had about a 42% decrease just in that year's time. So the work that we're doing with our partnerships with the hospitals have a huge impact on this and our partners, other partners in the community and the work that we're doing. So we really appreciate your time for this, and we are happy to share our slides also. And I'll turn it back over to Ashley.
Thank you guys so much, and thank all of the teams that were here and sharing information. There's been a lot of conversation going on in the chat. It's clear that this has been impactful. We have a few minutes left. MRE is going to share the survey, asking you guys how you experienced this. And while she's doing that, I want to open up the floor to any questions that people might have. And feel free to just come off mute if you have any questions or type it in the chat. Seeing no one coming off mute or raising their hands. I saw Amanda, you got a lot of answers, but just wanted to check in to see if you had any further questions. You asked, does anybody have a patient navigator in their ER? It's something that you're working on. Did you want to say more or ask more about that?
I just no more questions, but thank you guys for put the information in the chat. This is something that we're kind of looking at doing here in Jackson. We're a population of 32,000, rural area with a lot of stigma. So kind of how this is going to go over with our ERs, but our police department chief is very, very supportive. He just put a Narcan vending machine in his lobby. So I think with his help, this is something we can do. So thank you for all the information.
And Amanda, just let me jump in super quick. I already answered you in the chat that we are building this, but again, to show how important it is to get this buy-in and these partnerships from this hospital, we didn't propose this. Our hospital partner proposed it. They said, we want to do a grant, to do this, bring you guys in, have somebody available for extended hours. So, I don't know if that would have been the case 5, 6, 7 years ago, where they were willing to put the work in, front the money, do that type of stuff. So our community partner has really bought in, and it's increasing our footprint and what we're able to do in healthcare in the county.
Yeah, I think our ER will too, once they see that it's going to be helpful to their nursing staff and everything. I think we're kind of wanting to do a pilot to see how it goes first. We've got the funding for a year to be able to do that. So I'm anxious to see. Hopefully they'll all be on board.
I hope I can be of help to you. Reach out.
From Columbiana County too, I will say, again, we're a smaller rural area, so we only have about 100,000 in our county. And so we are doing many of the same things, of course, that Montgomery County is doing, but on a much smaller scale. And I would totally agree that those partnerships are so important. And we started with a pilot county, or pilot city. We did not do the whole county all at once. So we started with just doing a pilot, and now we are in the whole county. So I think we got.
I see a hand raised. Lena, do you have a question?
Hi, I'm with Cleveland EMS, and we're starting a community outreach program. Just from the public safety standpoint, how do we incorporate ourselves into a hospital's ER department if they are starting a program like this? What would be your suggestion on that?
I mean, I'll take this. We're all common stakeholders that are working towards a common goal, right? And just like Columbiana County said, the hospital workers have a bit of compassion fatigue from going through this for, the past decade and a half. So going in there with strong ideas and getting them to understand how this partnership is going to benefit their patients, is going to benefit their staff. And again, use, if you want, reach out to us and we can help share our outcomes. So you can show people that, hey, we don't have it in our county yet, but Montgomery County does, or Hamilton County does, or Columbia County does. And this is the data that they have showing, how impactful it's been. Data always gets people. So, that's really, if you can lead with data, even if it's not your own, if you can lead with data from similar counties, and, similar to size and similar to, overdose rates and things like that, that can at least garner their interest, and then you work from there.
Thank you.
Well, being mindful of time, I just want to thank our presenters again. If anyone here has some additional questions, I just put my email in the chat. Please feel free to email me, and I can reach out to presenters to get more information. Thank you so much for being here, and we look forward to doing this more in the future. Everyone have a great day.